technical.
Great, thank you.
Down here on my own.
Wow, yeah, and thanks for inviting us. It's so nice to be here in real life as well, and not on Zoom, in leafy Exeter. So yeah, it's been great. So we can see the slides.
Just click down. Is that all right? So
Oh,
yeah,
yeah.
we've got like maybe using the pointer. Is it working? No. Is that all right? Just
Yeah.
click with the mouse.
Click
Sorry.
with the mouse.
It's not gonna be
Oh yeah,
most,
to click onto the things. Great.
I
Okay.
don't know what's going on there, but
Excellent. So yeah, we're going to talk about the trace DMT therapy model that we kind of nurtured through the trial. The trials that we worked on were really not just us, not just Michelle and I. I mean, there was so many people involved, so we should give acknowledgement to all the team at Small Pharma. Oh, I can see it at the back there. That's good. So all the team at Small Pharma. So I won't read the names because you can see them. Otherwise, we'll spend half the time doing this. So Imperial College team. I should mention David Arizzo as the chief investigator. We worked at Hammersmith Medicines Research, which is a 140-bedded clinical research organization in an industrial estate in West London. So not where you'd expect to be sort of having psychedelic therapy in lots of ways, actually, but quite an industrial place, but a great clinical research organization anyway. So there's a whole team of people we worked with there who supported the trial.
Yes, so we had Dr. Rosalind Watts from Imperial was our psychology advisor. She brought with her the ACE therapy model that we kind of adapted for DMT, but we started off using her model. Tim Reed was our psychotherapy supervisor. And as you can see, the therapy team initially was just myself and Graham, and then it grew as we went multi-site to lots and lots of therapists helping us and a few other psychiatrists. And we'd just like to thank 32 healthy volunteers Phase I trial and the 34 patients for the Phase IIa trial.
So we're going to be focusing on those two trials. And then after the Phase II trial, there were some other trials. So more Phase Is until the bubble burst and until it all ended in London, and then in Liverpool too. So we'll just introduce ourselves a little bit more. Can't see the mouse pointer. Yeah, got it. So yeah, just thank you, Celia, for the introductions. I'm an NHS psychiatrist, or I was an NHS psychiatrist, spent 15 years in mental health services in the NHS from 2006. And then in end of 2017 into 2018, that's when I joined the Imperial College team as an assistant guide, as much as I could get away from the psychiatric hospital where I was working. So a sort of part-time assistant guide. And then I left the NHS in 2020 to work full-time on the DMT trials, having got in touch with David Arizzo. And then after the end of 22, became contracted to work on the trials as well. So became a bit more of an independent contractor. And before that, I have to say, as an disclosure, I was employed by Small Pharma. But on the first day of the job, I think we all realized there was a potential ethical issue there, potential bias. So I was kind of ostracized behind an ethical wall, and I had no contact with any of the business of Small Pharma, just focused entirely on the trial. Now I'm working in independent practice. So I'm working as a private psychiatrist in Brighton. That's where fate has landed me. And I'm an advisor to the Institute of Psychedelic Therapy as well, and Luminate, which is an app that turns your phone into a strobe light and takes you on psychedelic-like experiences.
Yeah, and just to say a little bit, so I'm a psychotherapeutic relational counsellor, integrative relational counsellor. I've worked in private practice since 2012, and then in 2015, I joined Imperial College's psychedelic research team, where I was first a volunteer on their first Psychedelic trial, and then I stayed on for the Psychedelic trial as a lead therapist. And then I think 2020, I joined Small Pharma with Graham, and then we started working on the DMT trial together. I'm still consulting a little bit with Cybin, passing the baton over as it was, so they're now carrying on with the DMT work there. And I've been an advisor to the Beckley Academy, their sort of foundations course for psychedelic assisted therapy. and do a specialist integration group on integration with the Institute of Psychedelic Therapy. So today, what we're hoping to cover really is just briefly the Phase I and IIa outcomes. The development of the TRACE approach, a little bit about assessment and screening, so how we negotiated through that, the importance of presence, which always feels fundamental to us in terms of psychedelic assisted therapy, somatic preparation, how that developed through doing this trial, the classics, prep, dosing and integration, and just a little overview of the elements of the TRACE approach, sort of highlighted with some of the case studies from the trial. And thinking, I suppose we were thinking about developing and training and going multi-site. So therapist cohesion and team cohesion became something that we were actively thinking about, but didn't really get that far yet.
Okay, so there's going to be very little science in this talk, very little clinical science, I would say. But for those people who might not know about DMT, it's a naturally occurring, very fast-acting, very intense psychedelic tryptamine molecule. Provides a very deep and immersive psychedelic experience. First synthesized a long time ago, before the Second World War. First used for its psychoactive effects and explored, as far as we know, in 1956 as a molecule by itself. In the early 90s, Rick Strassman used DMT in his research, the spirit molecule research, but he was really looking, ostensibly at the physiological and subjective effects, not the sort of therapeutic effects, although he clearly sort of took a sort of psychotherapeutic view of some of the experiences. And then, 2015 to 2018, there was some research using DMT, ayahuasca in Brazil, that was really kind of looking at the potential for it to be a treatment for depression. And interestingly, in that research, they were using ayahuasca, but not really a kind of setting and therapeutic holding that we would sort of understand, or that we were doing. So this is just a whole lot of pictures of our time in the trials. We put it up there really just because it's nice to look back on and reflect on. It was a good number of years of our lives. Fair amount of time getting the whole place set up and prepared and getting the decor done for the room. We had a mountain of eye shades, the Mindfold eye shades that we ordered. We tried to make an IV infusion pump look a little bit more natural and fit in with the natural decor. So I actually superimposed those IV leaves on there, but we had sort of a string of ivy around it to try and, that was kind of our joke as well, with the ivy. And
It's scraping the bottom of the barrel, but it helps.
Yeah.
Taking DMT.
Holding
Holding
it
lightly.
we love the scones in HMR, and we went and ate lots of those. That was a picture of us at the very end, bottom right, as it all kind of ended quite suddenly. So that's the journey we've been on. So before we did the therapeutic trial, the Phase IIa trial, we did a Phase I trial, and this was at the end of this was the beginning of 2021.
Mm-hmm.
And this was kind of looking to try and find what the right dose of DMT was going to be for people. So we were giving people the intravenous infusion, a slow intravenous infusion of DMT, cohorts of including placebo experiences, and really kind of trying to gauge what was the safest and most potentially therapeutic dose and tolerable dose. And something that was really interesting for that part of the study was that everybody was psychedelic naive. So, and some people had never really had a drug experience at all, and some people didn't really even drink alcohol. So for some people, it was really their first altered state experience, and for that to be DMT was quite a big thing for people. But it was fascinating to do that. I mean, really, we found that there were no drug-related serious adverse events. If there were any adverse events and side effects, then they were short-lived and usually reported on the dosing day and resolved very quickly. And they might have been things like, feeling a little bit anxious afterwards, or not sleeping so well, having difficulty getting off to sleep, you know, that kind of thing. Occasional headaches, occasional sort of muscle aches the next day, but things that were quite mild and resolved quite well. This is probably as close to science as we get, but this was the top line results from the Phase IIa trial. This is the depression trial. We had 34 people in the trial with major depressive disorder, and everybody had failed, well, had not had remission from their depression with 2 treatments, and that was usually an antidepressant, usually 2 antidepressants, but sometimes also CBT. You know, they had to be sort of recognized treatments that were evidence-based. Everybody was weaned off their antidepressants. Oh, I was going to say also that a big part of this trial was finding people who were depressed enough, and the difficult part of this trial was screening out people who were depressed but not quite depressed enough on the clinical rating scales, which was a really tough thing to do, especially when we needed to get the trial going and lots and lots of interested people. And, you know, people that are really motivated are probably not the people that we, you know, need to be working with. So that was a challenge. Everybody was weaned off, and some people were off antidepressants. They'd given up on them before coming into the trial. Some people we had to wean off their antidepressants, and so that was something that took a little bit of time. Everybody in the trial had 2 sessions. The first was 50-50 placebo or DMT. The second was definitely DMT, and they were 2 weeks apart. This paper hasn't been published yet. This is the information, the sort of information that Small Pharma put out. So the primary endpoint was at 2 weeks, and really we showed that there was quite a significant reduction in the MADRS score. So that's the Montgomery-Åsberg Depression Rating Scale, which is a standard scale for using in depression trials because it's very sensitive to change in depression. So there was a 7.5 point reduction in the MADRS scores at 2 weeks, which was statistically significant. And then, you know, that was even greater, that reduction, at a week. So it kind of demonstrated the very rapid acting effect of DMT with therapy for people with depression. At 12 weeks, over half of people were in remission from DMT, from depression and DMT. Definitely worn off by that time. Thankfully, yeah, it wasn't due to anything. And of those people who were remitted and were followed up at 6 months, 2/3 of those people were still in remission at 6 months. And so these were better results than I think Small Pharma or us had anticipated, and you know, really very, very positive. And when you're doing a trial like this, it's really hard to know, and we were blinded to what these outcomes were, and it's really kind of hard to call it, really, because you're in the weeds, I suppose, with in the trial. So really, really positive surprise. And again, no serious adverse events were reported. Everything was mild to moderate, resolved fairly quickly, but nothing that, you know, caused any great concern. So yeah, this was just the door of our office at HMR. I think we were the first psychedelic trial in HMR. I think we wanted to rename it Hallucinogen Medicines Research instead of Hammersmith Medicines Research, because there were an increasing number of trials that came along and joined us in that research organization. But we had this dedicated office mainly because we had to screen people. We needed a space to do that on a regular basis. But it was really a space for us to talk about cases, to really think, you know, prepare and think about the people we were working with. And we developed the TRACE approach because we had to, really, because there was an aim to move on to bigger trials, multi-center trials, multinational trials. Everything sort of had to be scaled up. So we had to find a way of communicating what we were doing, to try and make sure there was consistency, and we could actually train people in a, you know, efficient enough way, train new therapists to work with DMT in the way that we had been, and the way that, you know, helped getting the results that we had.
Yeah, so our approach, the TRACE DMT approach, really, so I suppose what was important, that it was a time-limited, relational psychotherapeutic framework based around the concept of psychological flexibility. and built on the foundation of a person's life history. So it was a process that prioritizes therapist's presence and attunement to the individual's psychedelic experience. So that for us was, in a nutshell, what we were trying to train other therapists to be able to do, to be alongside and to support patients or participants through this experience. So yeah, we want to say it's not really a new psychotherapy model, but just a framework describing our approach. So, and it's developed organically and I suppose clinically from our experience, both at Imperial College, working with psilocybin, so working with depression there, and then also working with depression with DMT. So really, yeah, the essential part is it's time limited. It's working with people with depression and thinking about the intense, short-acting nature of DMT. So how do we prepare people for that? As I said, it was informed by Watson-Luoma, the ACE model. So Ros completed some qualitative analysis in 2015, where she came up with the concept of the ACE model, which is accept, connect, embody, which itself was based on Acceptance and Commitment Therapy ACT. And really, for us, from the work we did together, what we felt seemed really crucial in our capacity to support people through this was really having that comprehensive psychiatric assessment. So initially, Graham would do that alone, but then I began to join the session. So we would have me building that therapeutic rapport, and Graham as a psychiatrist, gathering all that knowledge of a person's psychiatric history. So in tandem, it's the relational and the psychiatric history moving together. And we felt that starting to do those interviews together meant that we could start to build that therapeutic rapport from the offset, because within the time frame of clinical trials, there's such limited time that we can spend with all the participants. So as soon as you start to build that rapport, the better. So yeah, what was crucial in thinking about the development of the TRACE approach, that we're working with people with depression. They're going to have more relational challenges in their lives. The somatic component came to the fore because often people with depression are disconnected from their bodies. They often numb, and the potential for more challenging transpersonal experience comes to the fore because these are people who've been repressing and not going towards whatever it is that ails them. And what we found is that often the lived experience of the patient often correlated with the seemingly abstract psychedelic experience. So the fact that we had this deep understanding of their psychiatric history, we could then see in integration and in the dosing, we were more aware of what might arise and how it might arise in a more abstract way. So what we felt was important for us to consider when being alongside people through these kind of deep, intense experiences is who do we need to be for this person? What might be reparative for them? So thinking about their psychiatric history, neglect or adverse childhood experiences, how they've suffered, and how they might make sense of their experience. And thinking about, how all of that can lead to sustainable therapeutic change.
Yeah, I think that's that middle part, the lived experience of the patient, just reminds me of, all the way through the trial, we had this kind of experience of like, what's helping here? What's kind of making the difference? Is this the subjective experience? Is this a sort of biological thing as well? And before we started the trial, I think there was this, we both had healthy skepticism, and we had that all the way through, which is the right thing to do. Healthy skepticism about, is DMT an experience that can be therapeutically useful? From what we'd heard of DMT experiences and know of DMT experiences, that these things, it can be so abstract and so, otherworldly and bizarre. Can it really be meaningful? And I think through the phase one, we had a sense of, as far as we could, know somebody, that there were sort of these little threads that kind of followed through into the experience, and so many different kinds of experience as well, that you get this kind of archetypal classic narrative, the sort of, I don't know, we probably diss Joe Rogan a little bit too much, but the Joe Rogan narrative, there's a YouTube narrative of DMT experiences, and And actually, I think we found that so many people had different kinds of experiences. It was such a more varied than I was anticipating, really. And yeah, very unique to the individual. A big part of what we were doing was thinking about, well, the framework came from the concept of psychological flexibility, which has been associated, or inflexibility has been associated with depression and addiction. And so attempts to avoid and minimize unpleasant internal experiences, is that part of that inflexibility. And that can result in an inability to adopt healthier, sort of value-guided behaviors and ways of living. Those who are more psychologically flexible report lower levels of depression, anxiety, and distress during stressful life events. And psychological flexibility is thought to be something that might be directly experienced with psychedelics. It might be a key mechanism of change in psychedelic-assisted psychotherapy, and that's something that Ros Watts and Jason Luoma were arguing in their paper. And I mean, Michelle's already mentioned this, but we drew from the ACE framework, and that's how we started working. So just briefly, this is the patient journey through it. Probably most psychedelic trials, but certainly ours. The pre-screen was the first call, the first contact we had with people. So it was video call, running through some basic questions just to see whether somebody should come in to have an in-person screen, full in-person screen. So we were doing a lot more of those. And that's the very beginning of the therapeutic relationship, really. It's first impressions. It's where you can gauge whether you're able to work with someone and someone's able to work with you. And then, the prep and the dosing, that's often what we think of as one of the most important parts of psychedelic therapy, is giving people the psychedelic and being there with them and supporting them through that. And then all the follow-up afterwards. Oh, we won't get the animation. I'll try. Oh, tragic. But it's okay. This animates, by the way. So the way we were thinking about it, I mean, working with such a deep, short-acting psychedelic, where you're not really as able to have sort of a dynamic with somebody while they're on the experience, although obviously that does happen sometimes. You're not really interacting, you're not doing therapy with somebody while they're in a DMT experience. So much of the information, so much of the energy, so much of the contact and the important stuff was happening before the experience and in the integration support afterwards. So really kind of thinking about somebody's lived experience and where that goes in the integration process. So yeah, we were kind of thinking about it a bit like this, and that the foundation of this approach and doing it safely and effectively was kind of really knowing the person. And that led on to us sort of conceptualizing it as being like a tree, like a sort of tree structure. We needed a way to communicate some of this and to kind of communicate the importance of continuity through the trial and, really knowing the people we're working with, because, in clinical trials and probably in the future in clinical services, as there is in GP services and mental health services, there's so much fragmentation. There's so much room for, there not being continuity. So we felt that, well, I'll run through it, that a tree structure is an archetypal, organic, universal symbol, really. It's simple and it's complex, and it's something that we all know. It highlights that there's that root layer, that foundation. The weight-bearing components are knowledge of the person, and then the other parts that we'll go through, that sort of presence and the preparation. There's an interconnected nature of all the different parts of this approach. I think, again, separate them at your peril, really, or at participants' peril. There's a clear direction of travel through the model, through the framework. Integration is a very branching process. It can go down any kind of branch, any kind of path. Again, we needed to sort of think about consistency. So trying to do things in the same way across different sites. And it's an organic process. We were thinking of it. It's a framework and a metaphor at the same time. It's this tree framework. Yeah, and it resonated with the nature-based decor that we were doing. So it all made sense to us, and I think it still does. So it does. Again, I mean, what we were also wanting to center was the psychedelic experience. You know, we'd heard other approaches to psychedelic therapy being more about having a psychedelic experience and then bringing in therapy during the sort of post-psychedelic phase. You know, you might have increased psychoplastogenic activity, increased neural connectivity, and then, you know, you do therapy at that point. But in our approach, we were really kind of trying to center the psychedelic experience and the quality of that subjective experience as well in the context of a knowledge and an understanding, a shared understanding of somebody's background. So this is kind of how we were thinking about it.
Yeah, and integration, as you can see, is at that top bit just after the experience, just before the different branches. So for me, the sort of that organic symbol really resonates, because I think when we think about person, if we think about them as an interconnected organic process, like integration, then we're less likely to sort of compartmentalize or to concretize or to truncate. So in a way, yeah, I think it really works well as a symbol and a metaphor. So with psychedelic integration, I think what's most crucial is supporting the unfolding process, as Graham said, following the patient's sense of the direction. So whichever elements, and it wouldn't be just the transpersonal, often it would be a mixture of acceptance, connection, and the transpersonal, but whichever parts seem more salient to the participant, we would follow. And we would also be trying to encourage an openness and curiosity with that process. So that would be there right from the prep, just being open and curious. And even with, you know, intention building, it's like have that openness and yeah, be prepared to throw your intention in the back seat and just go with whatever happens in the experience. So part of it is also avoiding therapist assignment of meaning, which is incredibly tempting. So we can see perhaps areas that we feel would be useful for a person to go towards, but one of the key skills is actually doing less as a therapist. So allowing the meaning making to come from the client or the participant. Another element we had to think about in the clinical trials was really supporting distress and managing AEs if needed. So that kind of delicate dance between the unfolding process and allowing someone's process to unfold and knowing when the distress was too much and they might need further help or further sessions. And yeah, I suppose the key reason for integration really is to help sustain therapeutic benefit and change, and to do that in a way that's meaningful for the participant.
And so, yeah, just to also say it's kind of, yeah, different from this structured therapy approach. And one of the questions we had when we were sort of developing this is, how do you train people and how do you make it consistent when you're not using a manualized structured approach? When you're trying to follow what's happening with the individual, when you're trying to be open and patient-centered, you know, how do you train people to do that? And that was a challenge. That was the challenge we had, really.
So this is one of our first case studies, and for us it felt like, as you can see there in the tree image, we've circled elements that we felt were salient to this person's psychiatric history and then their integration. So this was a woman who was married in her 40s. She was the mother of 2 boys, and she was having regular therapy, so that was quite unique. People were not allowed to start therapy in lieu of the trial, but if they'd already been receiving therapy, they were able to continue it. So she was quite unique in having therapy all the way through the trial. So we were conscious that she had a premature birth and spent some weeks in an incubator. So our Groffian mindset would be thinking about how that might potentially impact the experience. We knew that she'd had a difficult childhood. There was violence in the community. She had a very critical mother. And dismissive parents who worked excessively. So she was, yeah, kind of quite abandoned, I suppose, as a child. She felt time distortion. And she said, this is a quote from her, it felt like 2 hours with infinity in the middle. So, you know, thinking about how one makes sense of that, that's quite challenging. And she also spoke about, I think when she went into the ascent of the experience, difficulty breathing, which is something that can quite often happen when people have a DMT experience. She said it felt like birth. So she wanted a hug in the experience and felt cold. She wasn't able to communicate this to us at the time, but that was something that seemed quite salient to her in particular. And I think, yeah, she said she felt an expanded sense of self, that there was a bigger me, and anxiety was nibbled away. So she spoke about like many dragonfly entities nibbling away at her, but it felt like it was just her anxiety falling away at that time. She then, I think she really kind of identified with the dragonflies and bought herself a necklace. And we looked into the symbolism of a dragonfly and its symbolic significance of transmutation and change. And I think for this particular participant, what she felt was really useful was this embodied sense of self-compassion. So something she'd never really felt before, had been unable to access for herself. So that was something, yes, quite deep and quite profound for her. And this led to greater acceptance in life. So she wasn't so anxious anymore. She had real moments of connection with her children and her family. But she did speak about her integration phase being quite emotionally turbulent, so quite up and down. But fortunately, she had therapy, so she was supported by us, but she had ongoing therapy. And in her instance, it felt that therapy was really crucial to sort of helping her navigate through what we can see as quite a deep and profound experience.
Just going back to the roots of the framework, what we tried to do really was, I mean, as we've mentioned, is really get to know the people that we were working with. That's the screening process. If you're a psychiatrist, taking a psychiatric history is something that in the NHS you kind of have to do within about 40 minutes, 45 minutes. That's kind of getting as full an understanding of someone as you can. And sometimes, you know, symptoms of mental illness and medication and current life circumstances and stressors can take up a big chunk of that. So really getting to know somebody's lived experience kind of gets squeezed out a little bit in time-limited services, as much as you might try. So we did spend quite a bit of time with people. I think it was kind of up to an hour and a half, 2 hours with people to get their story and to get a real sense of a whole lot of this stuff on the slides, really. So a sense of somebody's belief system, their culture, their network, social network, the supports, their values, you know, to try and get an understanding of what people are interested in, you know, whether just, you know, their fears. We also gradually also wanted to know, you know, whether people did extreme sports or liked roller coasters or bungee jumping, or, you know, just to get a sense of, you know, and whether any people had had any altered state experiences before as well. So really trying to get a sense of, it was more of a psychologically or psychotherapeutically orientated history than most NHS psychiatric histories, I would say. So it took a little bit of time, but it was very, very important for screening, because sometimes, you know, we might have somebody who, from a sort of basic psychiatric history, seems like they'd be okay, but there might have been, you know, other challenges like unresolved grief or trauma that was still very alive and real for that person. So we really wanted to be sure we weren't going to cause that person any harm, or there to be too many complications in a time-limited trial. There was a limit to how much support we could give to people in a clinical trial.
So now kind of moving up from the roots, really what we felt was important was that knowledge and understanding, which was sort of all gathered from psychiatric history, and also that felt sense of the person. So that sense of building the rapport, therapeutic rapport, starts really at this point. And I suppose having a real sense of the participant we're working with, but also what becomes crucial is the the therapist's knowledge of themselves and their own kind of inner work, so that we know that what can happen in any therapeutic process is that transference or enactments can happen. So if somebody had a very stern mother, I could become that mother in the session. So an awareness of the person's psychiatric history and my own issues around my mother are very crucial to sort of have those in mind when thinking about how we hold this space. And this, yeah, I think this describes quite well what happens in the psychedelic experience. So it's a simultaneous journey inward and outwards. To plumb the depths of our psyche, we need to trust the outer world to keep us safe, mimicking our early attachment as infants to caregivers. The relationship with the guides offers an opportunity for a reparative experience of security and deeply felt safety, which can be profoundly healing. It's a good way to think of what could be happening in the experience. So therapist presence is for us foundational for, I suppose it's that capacity to be alongside somebody in these very intense experiences. And in what that means is really, it's the importance of the non-verbal communication. So we feel the skill and the confidence of the therapist will be intuited by the patient. So if you're quite new and you don't feel quite safe yourself, you don't feel quite secure, if you're not able to be that regulating other for the participant when they're in that deep psychedelic experience, they will feel that, and that will impact their experience. So, you know, it's really important for therapists to have done their inner work and know themselves and be able to kind of regulate for a person in that deep psychedelic space. And these are some of the factors that impede the therapist's presence. So if the environment's disrupted, that can unnerve the patient or the participant and the therapist. So if things aren't as they should be, if those transferential dynamics, so if you don't feel comfortable and you haven't really explored the relational dynamic between you, that can arise in the psychedelic experience. It's really important to be open and transparent with each other. If the therapist has a lack of awareness of their own inner process, so they have a feeling about a particular patient, like they remind them of their father, and that plays out in the experience, then it can really get in the way of allowing the person to have their own psychedelic experience. Stress and overwhelm, of course, a lack of grounding practices. So as a therapist, you really need those self-care practices to make sure that you are kind of centered and able to be there for people in that space. A lack of supervision could be quite detrimental. So we had supervision regularly, and Graham and myself, we would talk about each participant, and that just ensures that we don't get carried away with our own ideas of what's happening. It just ensures a safety, really, and that we're accountable to others. And then when working in a clinical trial, there are lots of other people involved. So there can be pressures from the sponsor to dose people quickly, which can cause real problems. So it means you can't build that therapeutic rapport, and you feel the pressure of having to complete a trial because for financial reasons. And then communication between different team members can also cause issues. So all of these factors can impact sort of the sanctity of the space, as it were.
And really, I suppose these are all about the setting, aren't they, as well? The setting in which you're working, and then the mindset of you as a therapist, and the set of the participant too. And yeah, so much of this can happen in research trials. So yeah, second case study. This was the first person that we gave DMT to in the phase II trial. So she was a woman in her 30s. She had a daughter. She'd been depressed for 4.5 years after the birth of her daughter. So I think it's 6 months after the daughter came along, she became very depressed. She had quite an anxious temperament, so she was quite anxious when we assessed her, but very, very tearful, very, very low. It was just so evident how much she was suffering. Her mother also had postnatal depression, and when her mother started to have treatment when she herself was 11 years old, her father then became very depressed. There was this was happening in her family as she was growing up. In the experience itself, I mean, she was somebody who probably drank a little bit too much and too regularly, but had never had any other altered state experiences. And her DMT experience, I think about roughly 10, 11 minutes in, she got very, very frightened as her ego was dissolving. The experience for her was so visceral. It felt like, you know, a physical experience that was kind of really almost in contact with her skin. It was such a deep sort of somatic and tactile experience. But she felt that she was dissolving and there was a fragment of herself that was being taken towards a vortex, a wormhole of some kind, and that she was going to be annihilated. And then in that moment, she needed a lot of reassurance and support. She took the eye shades off, she came out of it, she took the headphones off. And this was the first person that we dosed with depression. So we were thinking this is going to be an interesting trial, but so she needed a lot of support to reassure her that she was alive, that she was, you know, that things were real. But in that moment of just before she was, you know, thought she was going to be annihilated, she said she realized that she liked herself and she didn't want to disappear. That was incredibly powerful for her, and I get goosebumps whenever I think about that. When she lay there afterwards, with the support and reassurance, she was able to stare at the ceiling and just realize that she could just stare at the ceiling, that her mind was now quite clear. She said, you know, beforehand, she was always ruminating, always thinking, always anxious thoughts and depressive thoughts. And that continued. It's like she had developed an ability to be more mindful. There was more metacognition. She was able to sort of be in the moment more. She found her voice because she told us in no uncertain terms that the experience had to end when she was very frightened. And that felt like a powerful experience for her too. Yeah, and afterwards, really, she noticed a lot more inner peace and happiness and joy after the experience. She realized how much fear had dominated her life, and that those were her ego's way of protecting her. She had more insight and compassion for herself. She connected with her daughter. She was very distressed by the fact that she felt disconnected from her daughter, like blunted emotions and, you know, more irritation sometimes than positive feeling. And she continued with meditation and visualization. She even developed her own visualization practices as well, which is very different from what she was doing beforehand. She was more able to focus. She had a really significant increased quality of life. She started doing craft and getting much more involved in mindful activity. The challenge for her was that, I mean, I think she was one of the people who, after 4.5 years of depression, scored probably no more than 3 on a MADRS scale. It was incredibly low. Like, she was in remission from depression the whole way through, even when a couple of months later, her partner became incredibly depressed, mirroring what happened with her mother and father as well. And actually, yeah, he tried to take his own life a couple of months into that, which was incredibly distressing for her, but didn't precipitate a relapse of depression. She was able to she needed a bit of extra support from us, but there was something different in her ability to kind of cope and manage, and then something in the family and the dynamics and the systemic field, I suppose, that changed as well. So I'm aware of time,
Yeah.
and yeah, what time do we have to leave the room?
5. And we can have questions.
5, okay. Try and speed through. I'll try and speed through some of this. Just to say that our colleague Emma Louise, a therapist in Liverpool, started to develop, we all kind of worked on it to a degree, this kind of preparation workbook, which was to help people prepare for the DMT experience. The idea was, after the screening and before the dosing, there should be about 2 weeks, and then people could go through this workbook to try and help them be more aware of their body, more aware of the present moment, and self-directed exercise that really helps people get more participating in their own healing journey. and better prepared for what can be, you know, a very intense experience. So just to whiz through, yeah, some guided visualizations. We had a mountain journey analogy, which Ros Watts developed, which was a guided visualization. So it kind of fitted with that. It was about mindfulness, breathing, grounding exercises, introducing the concept of the inner healing intelligence, which is quite common in psychedelic work, and then a bit about forming intentions and encouraging courage, compassion, and curiosity.
So yeah, I was thinking about embodiment, and so this was a participant who had, yeah, embodiment was a key element of his experience. He was an Asian British man in his late 20s. His family were very strict, so he had good relationships with them. From his early teens, he had a pattern of avoidance of schoolwork. It was very difficult for him to motivate himself to do it. His DMT was intense and emotional, but very embodied in nature. He talked about dropping into a dark, fearful space when he slowed his breathing and focused on the music, but he was able to bring himself up and out. The dark space manifested as shaking in his limbs, which he connected later in integration with his childhood nightmares. So he would often wake up as a child shaking. He said a lot of different emotions I went through, it was an intense and grueling roller coaster ride of feelings. He said he felt at some point profound loneliness, but he was able to stay with that loneliness. And a lot of the preparation for psychedelic experiences is to be with the feelings. So for him, it was actually being able to stay with that loneliness and go in and through it that was, yeah, really useful for him. So it's acceptance of feelings that he'd been trying to resist for a long time. He also felt himself merge with infinite space, dissolving into it. There was no me for it to center around. And he felt this deep sense of awe, which can also be quite common in psychedelic experiences. And it's usually really useful and an indicator of depression remission quite often if people have these mystical or awe-inspiring experiences. So the day after, he was able to connect to humor. He was laughing at comedy, and this was something he hadn't been able to do for at least a year or so. He found meditation easier. He was less distracted by his thoughts, and he was able to connect more with his family and friends. So he'd been quite avoidant of social contact before that. And he said that he also started bouldering, so he found his way back to his body. He sort of became more aware of how disconnected he'd been from his body. So he said that for him, the benefit from the experience shifted towards more physiological than psychological. So he kind of imagined he would get this map of his psyche, but what he had instead was this reconnection to his body.
So very briefly, this was the room that we were working in, low lighting, the obligatory salt lamps, battery powered candles, which took us a while to realize they were not real, even we knew we put batteries in them. They flickered, which was nice. So we played birdsong into the room as well. So we kind of had this sort of natural feel about the space as far as we could in an industrial estate with a great big roundabout outside. I mean, that backfired a little bit because sometimes if we were like on a weekend out in nature, you hear birdsong, it makes you feel like you're at work, which is kind of not ideal, but we enjoyed our work, so that's okay. So just briefly, and then probably a lot of you will know a lot of this process anyway, so we won't dwell too much, but the day before the DMT experience, is this your slide?
This is slide, you were going with this.
No, I'll hand over to Michelle.
Okay, so for preparation, we were thinking, mainly about, explaining to people what to expect and without priming them, which is obviously really difficult. So we would talk about, ego dissolution, ontological shock, and all of this would be, well, this would not be the day before, but we would be doing this in the screening, but we would maybe revisit the phenomenology really of the DMT experience. So managing expectations, so trying to unhook people from wanting the Joe Rogan experience, really encouraging them to have their own experience and the benefit of that. Tuning and developing the rapport would be a crucial part of this prep. And resourcing for the experience. So we're hoping that they have ways in which they can, whether it's breathing or hand holding, ways in which they can navigate the experience and feel as relaxed as possible, given the circumstance of DMT being this very short, intense, fast-acting psychedelic. So that a key part of the preparation would be the mountain journey visualization, which would take about 15 minutes, and it would give people the opportunity, thinking about people who are psychedelic naive, to sort of be on the bed, have an internal experience, get in touch with feelings, drop into the body. And sometimes people would be able to get in touch with an intention that kind of spontaneously arose from the experience, rather than some intellectual or cerebral intention. So it could be quite useful, and it would give them a sense of what it's like to be with us and to be supported by us in the room. In that, we would also be negotiating physical contact, making sure they felt comfortable with the hand holding. We would sometimes put our hands on their shoulders just to check to see how they're doing. Exploring fears and anxieties. So often speaking about them before the experience usually ensures that they don't arise. And I suppose quite fundamental was really making sure that they were psychologically ready for the experience. So like just checking in to see whether they really wanted to go ahead.
So the dosing day, it was much less information giving, in the preparation. It was much more about checking in with the person, kind of helping people be a little bit more at ease, obviously trying to manage the anticipatory anxiety that can come, certainly when you're very depressed, but also, before a DMT experience, that's quite a natural thing. So we might have done we did do the mindfulness body scan, breathing exercises, about trusting the process. We talked about that, the unfolding process, and then a slow infusion of DMT intravenously. And then afterwards, questionnaires, all the physical checks, the integration session on the day was an hour, and then we'd encourage people to draw their experience if they wanted to. We should include some of the pictures.
Yeah,
But they were great.
Not that we've got any.
So this was a case of somebody who was, try and whiz through it as quickly as I can, but it's details. So she was a 30-year-old woman. She had a very creative career. She still lived with her parents. She'd been depressed since her late teens, so definitely over a decade of depression. And that was, severe enough for her to be on antidepressants that whole time. I think it interfered with her ability to build romantic relationships, and she'd been single that whole time. She was a middle child, very shy, sensitive, tearful. She had an extroverted older sister and a younger brother who had OCD, and she didn't want to add to her parents' difficulties. So there was something very much about, growing up in that family dynamic. She struggled with SSRI discontinuation syndrome as we were taking her off the SSRI. And then she had a placebo experience initially. And she turned that on herself quite a lot. There was a lot of self-criticism about, it not happening, very powerful inner critic. And during that first integration session of the placebo experience, we were talking with her about, it came to be talking with her about the first 6 weeks of her life, when just after she was born, she was distressed and inconsolable for about 4-6 weeks because she had some neck pain, which I think ultimately no one knew what to do until she was treated by a chiropractor, and then it resolved. This is the story that she tells. So there was quite a lot of distress from the beginning of her life. Between admissions, she did seek help from her parents. She was able to kind of voice her distress a little bit more and receive help from her parents, which was always a challenge. And then she had the DMT experience 2 weeks later. And ultimately, this was a very, very challenging experience for her. And she went straight back into a womb-like space in this experience. It was a dark, empty space, red and pink. There was this kind of awful sound that made her think that something had gone horribly wrong and that she was going to be stuck there forever, trapped, separated from everybody, unable to ask for help, feeling like she was dying, felt incredibly intense. She felt this pressure on her head. She described this pressure on her head, which she'd never really felt before. And sadly, really, the experience itself didn't lead to any kind of resolution, and the integration was a really challenging process. There was a return of her depression and anxiety, which seemed to get as bad as her late teens before she even started SSRI treatment. So there was a sense of she felt her feeling detached, really struggling to function, very distressed, feeling very powerless. And we had to do additional calls with her to support her through that process. And really, we had to discuss her restarting antidepressants because her mood was so low. And she did that, on my advice and advice to her GP. And then gradually her mood started to improve again a little. And she was able to reflect on the experience. There was something of value psychotherapeutically, and that she was able to kind of think about it as an intensification, as something that really showed her what some of her difficulties are and what her depression is about, and how she might sort of take it forward. It felt like an important step on her journey, but it was very, very difficult.
She wasn't ready to really go there therapeutically at that point.
No. And for us, it was this kind of, I'll just try and summarize really that, we had a framework that we were using around acceptance and about sort of finding ways to sort of be with the feelings and not avoid experientially. But we had to balance that with the fact that she was really unwell with depression and that she needed help and treatment for the depression. So, we had to hold the framework quite lightly and think about what was best for her. And, when she wasn't able, in the right place to do some of that sort of psychological work, then, she needed to get, additional help. So she was someone for whom it was considered a useful experience, but didn't resolve her depression. If anything, it continued to get worse.
How long was she off SSRIs for?
Before the dosing, I think between 2 and 4 weeks.
It's quite brief. Isn't it?
Still quite brief. Yeah. So we will whiz through these quickly. Yeah, essentially. So what we tried to do actually, because we normally go through this and then don't have enough time for the case presentation, so we thought it'd be more interesting to bring the case presentations forward. But we've kind of covered a lot of this already, in the sense that, thinking about the transpersonal side of the experience, this is obviously what DMT can provide a great deal of, with the mystical or ego dissolution, the symbolic, ontologically shocking sort of part of the experience. Our approach was really about, being open, being alongside, being ontologically humble, as far as we could, holding it lightly, helping people ground, exploring the meaning, that individual's meaning, really. So it's that kind of open, patient-centered process.
We did, and the dreams part was very interesting. We did often ask people about their dreams before and after. Some people had dreams that were related to the dosings, almost as if it continued into the dream world, parts of their experience.
And then when we were thinking about how to train other therapists to work in this way, we were thinking about how to, like, using dreams as a sort of as the approach of how to explore somebody's dreams with them without going, hey, I know what this dream's about, and like giving their own advice. So it was useful in that way.
So the relational, really, again, it's just like curiosity and attunement, and being aware of the systemic network that the person is in, how that relates to them, thinking about, the patient and her family, where she became well and then her husband became depressed. So thinking about self-relationship, the role of the ego, the structures in life, and their altered state experience, and their relationship, how they viewed the psychedelic experience and what they might feel about encountering entities. So kind of exploring that with them. And ultimately, I suppose, with the relational, it's modeling self-compassion and self-care. So that being foundational.
Acceptance is really about the avoiding experiential avoidance, or kind of being more in the moment, defusing from negative thoughts. So staying with unwanted or difficult emotions, sensations, cognitions, using feelings as teachers and being able to kind of stay with some of the difficult stuff. That's all I'll say there.
Connection, again, just really identifying themes of connection during the integration discussion. Often it might be something that when we think about working with people with depression, they often feel very disconnected. So often the antidote to that is connection, and thinking about the values that they might be holding in their life and whether there is potentially any cognitive dissonance with their values. And yeah, how they might feel more connected, what that might look like, really. Embodiment, really, again, just thinking about how we make space for emotions. I suppose it can be relearning for people with depression, like how to read somatic cues, staying with sensations and seeing them as meaningful rather than something to be avoided. And the body can be a great aid in helping excessive rumination, so dropping from thinking into feeling, and exploring and encouraging self-care and embodied practices.
And in preparation for scaling this therapy framework, we were thinking about using this, whether it was this image or using the sort of tree framework as a tool for people to, be able to just quickly circle different things that were significant for, in a patient's history and then in the integration phase. Very briefly, just to say, part of what we were trying to develop also was robust structures for therapist team cohesion across different sites. Very, very briefly, the intense nature of the work, all the transference and counter-transference, and the stresses and the challenges and the potential emotional burnout that can happen in this kind of deep, intense work can make it difficult within teams and across teams. And so, we were trying to work out how to have a structure so that everyone can be on the same page in the way that they deliver the framework, but also,
Be themselves.
Be themselves and avoid a sort of silo mentality across different sites. So that's something we were working with. So coming right to the end, there were very positive results from our trials with DMT and with therapy, and these were proof of concept trials, really, and hopefully they're going to be getting bigger somewhere across the world as well. So. Screening, preparation, and integration was really, really important, and all of that around this very short, intense DMT experience. The relational element is key because these experiences can be potentially destabilizing or transformative. They're powerful, powerful experiences. The FDA guidelines has made it so that all companies and people doing research, therapeutic research, really have to sort of try and tease apart what's therapy, what the therapy is doing and what the drug is doing. This kind of, in our view, artificial separation from, between biological effect and experiential effect. And and that's a challenge for the whole field and could go quite wrong.
Quite wrong, probably.
So we feel that the therapy component is really foundational. We were not using an evidence-based manualized therapy approach. What we were trying to do was, as far as we could, treat every participant in the same kind of way. And then you had plus or minus DMT. Of course, the therapy was centered around the psychedelic experience. But trying to keep it as open and as open as we could. But all of that is crucial for safety, and we would argue also for making sense and using the subjective experience in DMT with DMT. So we hope that psychedelic therapy will be approved through clinical trials and in a way that retains the essence of this synergistic combination between medicine and therapy. So we'll just leave this on the screen. We both independently came across this image and thought, that's exactly what we're doing when we prepare people for psychedelic experiences. So we wrote a short, light-hearted article, which will be coming out in double blind at some point.
On the importance of the body one.
Yeah, so in about Coddy Wobbly, so, and, yeah, thank you very much.
Yeah, all could be one thing. I think that's brilliant. So yeah, I'm sure that's really fascinating. Thanks for sharing also, honestly. Has anyone got any questions? A lot of questions. Chris, do you want to go first and then you?
Yeah, I was interested, it's very double act, and I've just, there's quite an overlap in your roles, that's what I was thinking, because as what you're doing the screening, and also the relationship's really important. But you using the therapy, is that right? The
Well,
therapy.
I mean, we
Yeah.
learned from each other, I would say. It was a real synergy and maybe quite unique and unusual that psychiatry and therapy are going hand in hand through this process. And it was, I suppose, because we were doing the first trial and it just happened to be that way. But for us, it felt, I learned a lot about psychiatry. Graham learned about therapy.
Be there in the places.
Yes,
Yeah.
yeah.
So we were, therapist, co-therapist. team. I've always been a more psychotherapeutically orientated psychiatrist as well, but I'm not a trained therapist, so I became more of a therapist, and Michelle's become more of a psychiatrist. So.
Synergy.
Well, something else quickly, just, I mean, was it, obviously relationship's important. Do you manage to bring in people's spouses or others in the sort of preparation, integration stuff?
Not in human form, but
No.
sort of
In object form sometimes.
in thinking about the relationship.
Yeah.
And
Do they get much information about what's going on? Do you reach out to them? Do they have much information about what? Not necessarily, unless the
No,
questions.
I mean, it's a great idea and I think it's a really
Yeah.
useful thing to do, but trials and limitations of money, but I think that's, a wonderful idea to bring the system in.
Yeah. Great, thanks a lot. Thank you.
Thank you for your talk. There's clearly a big emphasis in this framework on sense making, and particularly with the kind of more abstract, bizarre elements of the experience, and trying to tie that into someone's direct daily life. And if I understood right, you do an integration session like on the day of dosing itself. I'm wondering how that compares to a lot of advice in like ceremonial and retreat settings, where they will tell participants not to rush into trying to describe their experience to others, at the risk of kind of crystallizing the experience and creating a narrative, which is interrupting an ongoing process. So I'm wondering, if you think that there's a trade-off there, or how that can be managed.
So on the day of the experience, it was really them relaying their experience to us. So that would just be how they experienced it. And we would, in that process, tell them it would still be unfolding and that more might come to them and more might happen. So it wouldn't be until the next day that we would tentatively be thinking, is there anything meaningful in this for you? But still, this is an unfolding process. So we would all the way through try and encourage them not to overly concretize and to go with that unfolding process. So as much as we could, I mean, whether we achieve that, it's hard to know, but we would, so it wouldn't, the sense making would come as further along as necessary.
And sometimes it came like a month later, in the integration process. There's a guy that comes to my mind, a participant, a patient, who really struggled in the integration, for the early integration phase, to make sense of this, potentially quite traumatic experience where he felt that he was sort of devoured by this huge entity and the most difficult part of it was that this entity was entirely indifferent to him. It was just casually devouring him, and he found it incredibly distressing, and he really wanted sort of more mystical, wanted to find God, but in his experience, God was in the next room behind the wall and not accessible. And so this really powerfully, distressing experience. But it was only, I think, day 29, where he was able to kind of make sense of that and reflect on that. We were talking about, shadow sides, but he came to the conclusion that it wasn't really even just his shadow, it was his ego. It was what he's been doing to himself throughout his entire life. And this trail of destruction in his life had been because he was this kind of indifferent entity kind of devouring other parts of himself essentially, and kind of leaving, being sort of indifferent to others around him in his own ambition to be successful, which he incredibly was. So yeah, it took a fair amount of time, and us trying to sort of support and help that process, but not to intervene and to kind of encourage crystallization, but sort of trying to sort of hold it open and be curious, because actually he was somebody who needed a lot of support to sort of be reflective and curious. So yeah, but it was a powerful, and just a bit more information. He didn't really get better from his depression during the time of the trial. As far as we know, his scores stayed pretty much the same, but he went from saying that was horrific and horrendous, why would I ever want to do that again, to thinking actually that was incredibly useful. And he said he never wanted to forget it. He didn't want his life to continue to be guided by this kind of intrapsychic process. So incredibly useful psychotherapeutically, but not treating his depression. So yeah, the nuance. Thanks for the question.
Thank you. First of all, thank you. That was fascinating, really interesting talk. I've got quite a few questions, but if I have to actually narrow it down to one, I want to ask about the kind of like trial protocol. So there was kind of like two dosing sessions, I guess. The first one was like 50-50 between placebo, I would expect like saline and kind of like DMT. And the second one, everyone had DMT. Is this correct? That's right. And if I may ask, kind of like you had impressive results for treatment-resistant depression, but could the results have been somewhat like muted by the fact that everyone has had like the active intervention in the end of the day? Like in essence, if everyone has had placebo, people who had like placebo in the first one, had placebo in the second one, would you actually have found more significant differences between the two groups? Because in essence, one group had like active intervention and the other had very active intervention, the way I see it.
Yeah, that's a good question. I think I'm trying to remember the study design and the way they looked at it. I think there were MADRS assessors before the second dose. So when the 2-week endpoint was really that 2 weeks after the sort of 50-50. I think for ethical reasons, they included the second dose being a sort of open label. But it really was a sort of straight placebo dosing kind of comparison at that first 2-week point. And then we have all the questions about functional unblinding and knowing all the sort of challenging things about psychedelics and RCTs. But yeah, it was that 2-week point was just before that open label dose, if that helps.
Yeah, I think it does. Yeah, please.
Question from online from Eva. You can probably read it yourselves. Were the participants, I don't know, Eva, if you want to ask it out loud, or were the participants asked to set their own intentions, or did they enter the experience without direction?
Yes, they were. Yeah, we wouldn't. I suppose we would talk about the process of setting an intention and kind of encourage them to engage with that before coming in. And we often suggested that they could bring in intentional objects to signify their intentions. But we would encourage them also to be open to changing. So when they had the mountain journey body scan, we were like, if another intention arises, then maybe you could bring that into the session. But with intention, we would be like, hold it lightly. So have that intention. So in a way, what are you bringing to this experience? But don't like overly fixate on it. So like put it in the back seat, and then you might find inadvertently your intention plays out. But you know, if you overly focus on it, then you kind of your expectations might get in the way of the experience. I suppose unfolding more naturally.
Johnny?
I was wondering if, because it's quite a short-lived experience, I was wondering if there was a component where some participants may want more follow-up infusions afterwards to kind of maintain therapeutic benefits, and if that's something that you think would happen in a potentially licensed and distributed therapy later down the line, if maybe further maintenance and more infusions would be a part of it, or whether it is effective and desirable to keep it at 2 or even 1 infusion.
I think in real life, it would be very patient specific. It might be that over time we get a sense of perhaps a little bit, I mean, I don't know how much ketamine treatment has evolved guided by the research or guided by clinical experience. But you know, over time, you might get a sense of how many treatments would be useful, but everybody would likely have a different time scale and a different amount of time needed to integrate the first experience. And certainly in the trial, you know, I remember someone who had a really incredible subjective experience that was incredibly symbolic and incredibly well articulated, and there was so much about it that was incredible. And she had this amazing antidepressant effect that after years and years of depression, it was like she turned inside out, in the sense that, you know, that where she was empty, she was now full. It was such an incredible effect. But after about 6 to 8 weeks, I think it was, she was starting to relapse and starting to feel depressed again. And that was such a sad process, such a difficult process to witness, and so difficult for her. And I think she managed it incredibly well, but to have experienced being well and then to relapse, it was we all wish we could give her another experience, but we couldn't. She did have 2 experiences, and there was a narrative arc that went over both experiences, which was quite remarkable. But so in real life, I think it would be as tailored to the individual as we can, and probably with multiple doses.
So at this current point, how effective do you think it is as a long-term treatment or to produce long-term remission in depression? I mean, is that something that was observed at 3 or 6 month or even a year follow-up? Has that been measured?
So 2/3 of 57% who 2/3 of the 57% who were depression-free at 3 months were still depression-free at 6. And so for some people, there seemed to be quite a long, you know, within the limitations of our follow-up, you know, quite a long-acting sort of antidepressant benefit. But again, I imagine it would be, I mean, we saw people who didn't have any antidepressant effect. We saw people who got a little bit worse. One of my sort of favorite reflections on the whole thing and working in psychedelics, the research, is that this kind of conforms to the rules of any treatment. You know, that sometimes there are some side effects, sometimes it doesn't work, sometimes it does work. It's not a panacea. There's no magic bullet. It's not a magic. It's going to be very individual for different people.
I mean, you.
Yeah, just tagging to that one really. So you were saying, talking about this patient who was at 6 months, started relapsing. How much contact did you had with her up to that point? Were you just doing follow-ups, or was there sort of further integration of therapy?
So there was for her, it was the standard. We didn't go off-piste at all. It was kind of the 2 doses and then an 8-day check-in, 15-day, 15-day, then the sort of day 29.
Were you guys doing the check-ins?
Yeah, we were doing
being maybe like a sort of bringing back some memories of therapy. Sort of.
Yeah. We had specific integration sessions. So I think it was trying to remember, it was the day of the dosing, the day after dosing, and then day 29 was the sort of planned integration sessions. The rest would check in, and we wouldn't be going sort of into those thinking, let's do more integration. But if stuff came up, of course, we would say, hey, bank that for day 29 or something like that. So it was kind of, again, still quite sort of tailored to the individual.
To be honest, I do feel that more integration sooner after the experience would be very helpful. Like, you know, day 8, you could have had one at day 5. Having them sooner, I think, would actually help people make sense of it and be more, whilst they're in that sort of psychologically flexible state, I think.
I was just curious about because your sort of outcomes were like remission over time, right? So you're looking at how long people stay well. And I was just curious about the kind of contact that you had with them and how much that might have contributed to keeping people well. And whether, if you were designing your kind of like dream intervention, would you add stuff into those follow-ups to keep propping people up?
I mean, it's I think as Michelle said, I think the sort of front loading the integration a little bit would be better, and maybe make more sense if there is that sort of neuroplastic psychoplastogenic effect.
And I
Yeah.
think these experiences should happen within the context, if it's clinical, within the context of a therapeutic relationship. So maybe over a year, you have 3 psychedelic experiences, but all the way through, you're having therapy. So that way, maybe it would be a year to really shift substantially someone's depression, but it would be a robust, slow process with the psychedelics just, facilitating or escalating that therapeutic process. So for me, that would be ideal, but I don't know whether that will happen.
With that, that's your-
Yeah, kind of.
Somebody have to just take one final question, so, or there's only got two.
Based on
So
the
quickly.
experiences you had and the experiences the clients had, will there be any like revisions to the trade framework, or is it like a stable, more or less framework, you think?
Yeah, good question. So for us, this whole thing kind of ended in June last year. So as far as we know, the Embark framework, the Embark model is kind of being taken forward because Cybin acquired Small Pharma. And so I think they're using the Embark framework with DMT from here on. And in lots of ways, the Embark framework is a very good framework and it's probably the most similar in its approach to what we were also doing. So it's yet to be seen whether the trace framework is going to be employed again. We hope it will be in some form or another. So either in real life in the future or in clinical trials.
Did you have a final question?
Yeah.
Yeah.
I was to ask, how much is the drug and the experience, how much of the results that you in reducing depression comes from the drug and the experience, and how much comes from the sort of therapy and the clinical aspect? And how different would it be if someone took a drug in a non-therapeutic or even like a completely different, so either maybe at home or in like a ceremonial situation? Would be any benefit to that at all, or do you think it entirely comes from a combination of the therapy?
Yeah, that is a great question. And I think that's what the whole field is going to have to try and work out. Perhaps the FDA wants to be the sort of decider of that. I mean, I probably could just say a couple of things that I think through the whole process, we've tried to be as open-minded as we can about the whole thing. I think maybe the sort of synergistic side means that I don't think either of us would entirely, well, I don't know, separate the two, that this is a powerful subjective experience. We know that it's potentially, stimulates neuronal connectivity in the frontal lobes, and there's a lot of evidence kind of in both ways. And I think during the trial, we've seen, we have seen people who have had powerful subjective narrative experiences that seem incredibly psychotherapeutically important and transformative and restorative, and what's the other word, sort of changing narratives from the past. And it seems like very, very compelling that was a subjective experience that made the difference. And then there's been at least another person that springs to my mind who said, I didn't expect to just stop drinking. I didn't expect, it wasn't anything really to do with the subjective experience. I just didn't expect to not want to pop into the off license and get a 4-pack on the way home every day, for what, maybe not every day, but this kind of unexpected benefit that didn't seem to fit with a psychotherapeutic narrative. But it was probably all of it, and in different amounts for different people at different times, and it's super complex, but I don't have the
I suppose
answer.
if we see them as non-specific amplifiers, therapy is just one thing you can amplify, but ceremony will be another way of working, which could be equally as powerful because you have the group as well, and that's an amplifying process. But it may be, in ceremony, there's a different kind of benefit to maybe working, and maybe it is a more group communal experience that in and of itself can have huge benefit. But I suppose they just work in different ways. And I think it's just remembering psychedelics as amplifiers, and it's just what do we want to amplify and thinking about that.
Yeah. And I'll just say all psychiatric treatment is not given without context as well. So, you know, even antidepressants have been argued to be, you know, amplifiers, and they can help with sort of plasticity and adaptation to change. And so none of our treatments are really like purely without context. And so the whole thing is, the more you think about it, even more complicated.
Please stand. Oh, well, thanks again, Michelle. Great. Bye, everyone online. We're going to the Citygate Hotel for some food and drinks, and anyone's welcome to join us. Sun's shining, so yeah, come along. Bye, everyone online. You can come along.